Hey guys, welcome to EMS Challenge. We're live at Jeff State. This mic is on up here, sir. Yeah. We're at Jeff State today. This is there's no skill lab. We just have lectures. We'll be at the state conference next week doing some things as well. But I'm going to let Dr. Douglas is going to speak first today. She's one of the senior residents at UAB in the ER program, doing her month of EMS with us. She's also got to work today in the trauma bay all day and half the night. So we're going to let her go first, and then we'll kind of get going from there. So as soon as Chief gets the mic cut off up here, we'll get started. Yes, sir. These millennials, you know what I mean? They just, it's just tough to get them to work. That was funny. I don't care who you are. Yeah. Yeah. Millennial by age, not by generation, right? Okay. I got more West jokes. So the longer you take, the more jokes I got. Yeah, keep them coming.
Hey guys, is this okay? Yeah, I know y'all can hear me, but everyone else, is it okay with? Okay. I'm Kendra Douglas. I'm Dr. Kendra Douglas. You will almost never ever hear me call myself that because I don't really, it's very odd and very weird to feel that way to be a doctor. Let me see. I didn't mean to do that. Hey Wes. I need my notes are at, if I can get it out of, while he does that, I'm from right here in Birmingham, and I'm one of the ER residents. And if you bring someone to UAB, I will probably be there. And yeah, I work this afternoon in the trauma bay, so I'm going first, which is good. I wanted to go first because no one wants to go after Ferg, right? Because his presentation is going to be so great. So I wanted to go first. So I'm going to talk about non-cardiac chest pain today. I was just telling, it's perfect. I was just telling Ferg that there are some more exciting topics than non-cardiac chest pain, but those exciting topics you don't necessarily see all the time, right? This is the stuff that you guys see every day. So we're just going to start off with a little anatomy. I am not super sciencey anatomy type. So this is just pretty basic of what we're going to go over for anatomy here. And we're just talking about obviously what you know that's in the chest wall, your lungs, your heart. You have some pretty important vasculature. And then one thing that people always forget about that's in the chest is your esophagus. People don't think that it's there, but it's right here and it's attaching your mouth basically to your stomach. So that's, a large part of chest pain too. So those are the things, everything here and the brain obviously we'll be talking about today, okay? So the biggest thing that I want to drive home today on this non-cardiac chest pain kind of talk is that 50% of cardiology referrals are for non-cardiac chest pain. So they took this poll throughout all the country, and here in the United States, the people that get the most, see cardiology the most, end up being for non-cardiac chest pain. And they found that out on the back end. I'm sure they're not always happy about that. But I think if we just try to do our due diligence on the front end, we can kind of offload some of that from them and not send people just for random cardiology referrals that they don't need, right? So first, we're going to start with the esophagus. Like I said earlier, it is what attaches your pharynx or your mouth, the back of your mouth, to your stomach. And it travels through the chest, kind of protected behind your lungs, your trachea, your heart. It's kind of back there. So people don't think about it often, but it tends to be a pretty big cause of non-cardiac chest pain. So the first thing we're going to talk about is gastroesophageal reflux disorders, obviously often called GERD or acid reflux. You may have this or think you have this, like if you after you eat some pizza, some spaghetti, something like that, something real acidic. you can have chest pain. So the definition of is backward flow of gastric contents into the esophagus due to improper functioning of the lower sphincter of the esophagus. It's at the bottom of your stomach, and there's a sphincter there called the lower esophageal sphincter. They were feeling real original when they named it that. And it can get relaxed, and the acidic contents of your stomach kind of backflow into your esophagus, and it feels really, really bad. I don't know if anyone has ever had like heartburn before, but it does not feel good. Usually the symptoms are like a burning pain in your esophagus, which is in your chest, chronic cough, hoarseness, nausea, dysgeusia, which is kind of like a metallic taste in your mouth. It's just a fancy word for metallic taste in your mouth. Often we see people like this who smoke. Pregnancy usually worsens it, caffeine, and just depending on what you eat on a regular basis, right? The biggest thing is when you go and you see these patients out in the field, they're going to say, oh, my chest hurts. And they might not even say that it's burning, right? They might just say that my chest is hurting. I had heartburn for the first time I was a kid, and I was like, surely I'm having a heart attack. Like, this is clearly, I'm dying right now, because it really hurts. And if you've never experienced it, it can kind of catch you off guard. It's certainly not fun. There's some big complications. GERD in and of itself, or acid reflux every now and then usually isn't harmful. But if you have it every day, the acid from your stomach can certainly take a toll on your esophagus. The complications of that is called Barrett's esophagus. And that's when we kind of get into the realm of being concerned for cancer. The treatments is avoiding the triggers, avoiding that spaghetti or that orange juice or whatever. Sleep with the head of the bed elevated. Big one is not going to sleep right after you eat, which this is Alabama, we all do. And medications. And Harvard had this quote. It says, not surprisingly, it's often mistaken for a heart attack. In fact, over 8 million emergency room visits for chest pain each year, severe heartburn accounts for over half of the cases in which actual heart problems are ruled out. Now, of course, you bring me in someone and you're saying, Dr. Douglas, they are having chest pain. I'm not like, oh, it's GERD. Like, I'm not doing that. You have to actually rule out any other cardiac, etiology. But pretty early on, you can kind of see something that and say, this is probably acid reflux. It started right after I ate. I get this all the time. And if they have all the risk factors. So GERD, the acid in your esophagus, can cause, like I said, this is Barrett's esophagus over on your right and esophagitis on your left. And as you can see, it just makes your esophagus kind of looks obviously not normal. Does this have a pointer? No, it doesn't. Oh, okay, gotcha. No worries. So you can kind of see it's kind of eroding into the lining of the esophagus, and over this side you can see they're even developing some ulcers from it. And so you can easily get frustrated, like, oh, it's just GERD. But in the long run, it definitely has some long-term effects, and it can almost I think it's like a 40% chance of it the Barrett's developing into esophageal cancer. Most people, these medications, these are over the counter. A lot of people know them. They're relatively cheap if you buy them over the counter. I can get them a little cheaper if I prescribe them. But for the most part, all of them are over the counter, and they work really well if you take them every day. The Pepcid and the Zantac, which are your H2 antagonists, they work quicker and they reduce the amount of acid secretion. And then these PPIs is what we call these over here. They block the last step in acid production. So these are some options if you do ever have someone who is having these symptoms and they say that it feels like heartburn. These are some of the options that they can take. Usually the Pepcid or the Zantac is going to work quickest. Okay, now into a bigger topic. Have y'all heard of Boerhaave syndrome? Okay, so this is not a very known topic, and people don't think about it often when it comes to chest pain, but this kills people. Like 40% of people die from this. This is a rupture in your esophagus. Usually we see it in people who vomit a lot. So your alcoholics, your cirrhotics, people with bulimia, they from the pressure in their esophagus from vomiting a lot, they tear their esophagus open. And if you can think about it, if you have some kind of gastrointestinal disorder that's causing you to vomit, just because your esophagus rips open, that doesn't mean you stop vomiting, right? Unfortunately. So you continue to vomit, and the acidic stomach acid and stuff gets into your chest, and that is no bueno. The symptoms is called a Mackler's triad. You don't always see all three, but it's chest pain, vomitus, and subacute emphysema. You'll kind of feel this. You'll kind of feel this with you press on their chest. I keep touching the mic, Wes. Are they saying that I'm making a lot of noise? No. Okay. And it feels like crepitus. It feels like crunchy, crackly. A lot of times we'll describe it as like Rice Krispies. It feels weird. The first time you feel it, you'll never forget it if you haven't felt it before. And the treatment initially, the biggest thing that is you're going to be doing is volume resuscitation in the field and getting them here immediately. Here. I'm not at the hospital. You can tell how much I get out. Not here to Jeff State, but to a hospital. But it is one of the most lethal GI tract disorders. Like I said, almost 40% of people die from this. So you can see all this subacute air. I don't know if y'all can see. It looks better on my computer than it does on the screen. But all of here, this is all air that someone has nicely put arrows for you guys. All of this is air, and it should not be there. And even here is a little more subtle here, but all of that is air. And it's not supposed to be there, right? It's supposed to be inside of the lungs, not outside of the lungs, right? And this is from this person ruptured their esophagus, and they're getting air, and it's kind of going into their chest wall. Also, they're getting acid and the stomach contents into their chest wall as well. This is something that makes me very nervous. It should make everyone very, very nervous. And I think it's because you don't see it often, and so it doesn't get the respect that it deserves. But this absolutely, like I said, kills people, okay? The brain. Now, y'all are probably like, these doctors don't know what they're talking about. Of course, the brain is not in the chest, right? But you'll be surprised at how often we see disorders from the brain, like mental health disorders, develop and present as chest pain. So a lot of the mental disorders or psychiatric problems that we see, they occur right here in the amygdala. This is getting very sciencey. I'm not going to take y'all into the weeds, so please forgive me for this another anatomy slide. But a lot of it happens in the prefrontal cortex and along with the amygdala. And like I said, just because it's not in the chest doesn't mean it's not coming from this. Panic attacks. This is very, very common. Chest pain from panic attacks, I think almost 30%. I know, because that's what my notes say. 30% of people who have panic attacks say they had chest pain with it. And just because it's, even if they've never had it before, never had a panic attack, that is extremely scary. Your chest starts hurting, you feel like you can't breathe. It feels like the world is kind of caging and closing in on you. You start to get sweaty, and it just feels like the world is ending. And that can be very scary. Now, usually these if it's happening in someone younger, obviously that makes you a little bit more reassured, but it's still scary for them, right? So the definition of a panic attack is an episode of intense fear causing overwhelming physical and psychological distress. They have chest pain, dyspnea, palpitations. Some of them get dizzy. They can have hot or cold flashes. Some of them can even get some paresthesias. And the biggest thing that we try to give these people, it's coping mechanisms that really helps with them. It usually, oftentimes, if they have good coping mechanisms, they can kind of get it before it even starts and before it gets bad, before they get to the chest pain. But oftentimes you can't. So even if they are full blown into a panic attack while you're there, the things that I would give them is I usually start with the little hydroxyzine, depending on if they've had this before. If they've never had it before, I try to start with hydroxyzine. The jury's still out on how hydroxyzine works for panic attacks, but we do know that it increased serotonin in your brain. I'm not sure if that's exactly why it works so well, because in my head, hydroxyzine also makes you really sleepy too. So are they just, getting a little bit more tired and just kind of calming down, or is it really the boost of serotonin in their brain? The researchers really don't know yet, but I'm pretty sure it's probably a little mix of both. Also, obviously, you can use some Ativan. In people who have these often, I'll usually start with a little Ativan. And they know the people who have these disorders, they tend to be very self-aware, and they understand and they know what they need, and they'll oftentimes talk to you and tell you about it. But a lot of these long-term patient educations and coping mechanisms, refocusing your attention, taking nice, slow, deep breaths, meditating, going for a walk. The literature kind of changed their stance on blowing into a paper bag, and the CO2 kind of reuptake. That's probably not how that works. It's probably just the belief that the paper bag works that makes it work. But whatever the case, whatever they need to do, coping mechanism is what's going to be better. But certainly it presents as chest pain, and people come in and it feels like they're dying to them, right? And it's not our job to determine what their chest pain is like and what they're feeling. It feels really bad to them. Okay. Okay, your lungs. These are probably going to be the ones that most people are more familiar with when you think of your chest. If you don't think of your heart, you think of your lungs, right? And this is another little anatomy slide. This is the last one. But you have your lungs, you have your trachea that kind of attaches everything to your lungs. And on your left, you have 2 lobes, and on your right, you have 3. And under there is a really elastic muscle, huge muscle called the diaphragm. And here's just some of the pathophys down here of how we do air exchange. The NIH says that 36% of all acute chest pain comes from a primary respiratory etiology. And that means that not something that caused the lung to have pain, right? It didn't come from the heart. This is a primary lung problem. And a quick definition before we get into this, I'll say pleuritic chest pain a lot. And pleuritic chest pain is usually chest pain upon deep inspiration. It can be at rest, but usually people have chest pain when they have deep inspiration or exhaling. That's what pleuritic chest pain is. So if you hear me say that, that's what I'm talking about. PTE. A PTE is a blood clot that develops elsewhere, hence the embolism part, usually in the deep veins of the leg, that travels to an artery in the lungs, causing a blockage in lung flow. These people almost always have chest pain. And the biggest concern with PTEs is about, for all the people in the country in the past 10 years, a quarter of them, their clinical presentation for a PTE was sudden death. So here's some funner anatomy. It's not like just a diagram. So this is a CT scan, and it's nicely labeled for you guys. So this is the ascending aorta, and you have the descending aorta in the back, and then you have your pulmonary trunk and the left and right pulmonary artery coming off, and you can see the dye is filling it. That's what right? Well, here, same thing. You have your ascending aorta and the descending aorta, and you have this huge filling defect right here. This is a huge PTE. It's called a saddle embolism. That's the one. You don't want to have any of them, but that's what you don't want to have. And you can see it's kind of crossing over, and you can tell how it can stop blockage, and you can't get the blood flow that you need. This person was probably really sick, and very well could have been one of the people who presented with sudden death. The symptoms usually are dyspnea, chest pain, cough, hemoptysis. If you give it long enough, most people don't last that long. That's a pretty late finding typically. And the signs are going to be tachypnea, tachycardia. They usually have some calf swelling or erythema, and you can see EKG changes. Now, this is a very controversial topic, because I don't know if you guys heard of S1, T3, Q3, T3. You almost never see it. I've seen it once. But it is like if they have that, they have a PTE, but they teach us that in school and they teach all of you guys that, but the odds of you seeing that are just very slim. Usually you're going to see sinus tachycardia. You could see like some T-wave inversions. You might see a right axis deviation just because of how the heart is made and where the EKG leads are, but usually you're not going to see these findings. But S1, Q3, T3 is a deep S wave. We're going to do some quick EKG. So you got P, Q, R, S right here. So in 1, you have a deep S wave, right? And then in 3, you got P, Q, R, S, T. You're going to have a T wave inversion, and then you're going to have a deep Q wave in 3 as well. If you see that and you call me on the red phone, I'm going to be like, whoa. You are a rock star, because I'm gonna tell you right now. I mean, I've never seen one. Usually all the PTEs I've seen, it's sinus tach. 40%, 44% of these people are gonna have chest pain initially, and then the shortness of breath is gonna come. A lot of people think that the chest pain might even come from anxiety, because the PTE, a lot of people a lot of people feel like an impending sense of doom. And sometimes they feel like the chest pain is kind of mixed with anxiety. You wake up, you feel like you can't breathe, and what do you start to do? You panic, right? I would panic. So, but you only see this S1, Q3, T3 like 4% of the time, and sinus tach, you'll see it like 45% of the time. So that's pretty common. The treatment is anticoagulation. We won't get into the weeds of that today because there are so many different options, but you can also lyse them with thrombolytics. Usually, that tends to not be our decision in the ER. We have a team that kind of comes in and decides, unless they're super unstable. If they're hypotensive, they're not looking too great, you can go ahead and lyse them. And then depending on how big or small it is, you need to do supportive care, give them some fluids and stuff like that. Ultrasounds. So, like I said, just a quick, before I start showing you abnormal stuff, I want you to know what it looks like normally. So this is how this ultrasound is looking up at your heart, right? And this is what it's looking at, and you can see how this looks like. So you got your left ventricle, right ventricle, right ventricle, right atrium, left atrium, and your tricuspid valve and your mitral valve. Okay, that makes sense. And how it's looking, that makes sense. Anyone have any questions about that? That's a quick and dirty ultrasound. Quick, my ultrasound attendings would not be happy with that. So here we are looking at some abnormal ultrasounds. So here for PTEs, the first thing we typically see, and the first thing I'm looking for if I do an ultrasound on someone with the PTE, is right ventricle strain. That makes sense, right? Because your right ventricle is pumping to your lungs, and there's pressure pushing back on it from the clot. It can't push the blood against the clot, right? That makes sense. So when you start seeing right ventricular enlargement, it's because it's getting larger because of the pressure, and it's not being able to push all of that blood out. So a lot of that blood kind of sits in that ventricle. It can't go out insistently, okay? And so you can see right here how this right ventricle, your left ventricle is doing the heavy duty. A lot of people will say that your right ventricle is only there to supply blood to your left ventricle. Pulmonologists wouldn't like that, but your left ventricle is the heavy hitter. It's what's pushing all the blood out to your body, right? Well, your left ventricle usually should be larger than your right ventricle because it's the one doing all the work, correct? If you do an ultrasound on someone and you're looking at the view, we have the same view we just had, right ventricle, left atrium, right atrium. You see how much bigger this right ventricle is in comparison to this left ventricle? It should not be that way. So that's a huge red flag to me. Now, you can see it in some other cases if they have really bad pulmonary hypertension and CHF, but this is pretty remarkable. This is another view. This is a parasternal short view, and here's your left ventricle, and you can see that right ventricle is just like huge in comparison. Okay, and this is another example of that. Any questions about that? No, that was quick.
So ultrasounds are coming to the pre-hospital world, folks. Jeff State has them. Other institutions have them. The AirMed has them. Mobile Fire and Rescue bought 40 butterfly devices and using them. They're coming. There's no risk to the patient. You're not going to cause radiation damage, poison, or whatever. You can't hurt somebody, but it gives you a lot of information. So we are not there yet, but in the next 5 years, I foresee a lot of EMS agencies doing this. Super easy. Even I can do it. So it's nice.
And it's quick, right? And it can, like Ferg said, it gives you a lot of information. At first, when I first became a baby doctor, I was very afraid of the ultrasound just because I didn't know what I was looking at. And it's hard to see. It's just like a lot of gray, a lot of black, a lot of white. I don't know what any of this stuff is, but the more you use it, you'll see that it's a great tool. Once you start using it well, you will always use it, and it can tell you as far as if they have fluid on them. It can tell you if they have a pneumothorax, which we'll talk about later. It can tell you if they have right heart strain. It can tell you if they have a pericardial effusion. It can tell you if they're on tamponade. Like, it can tell you a lot of things, right? And ultimately, a lot of things are going to be able to assist you. And by the time they get to the hospital, y'all have done all the big fancy stuff, and there's nothing for me to do. Y'all laugh. Why is that? That's the truth. So this is the ultrasound findings that you'll typically see on someone who has a PTE. Pneumothorax. Pneumothorax is the air in the space between the lung and the chest wall, or a collapsed lung. That's the very quick, dirty, simple, without physics kind of definition of it. I hate physics, so I'm not gonna do that to you guys today. But that's what it is. It's air in between the lung and in between the chest wall. And if anyone ever asks you to explain it to them, that's how I always explain it to patients, and they always understand it. I'm not always like, oh, the pressure in here, like that's too much. Air between the chest wall and the lung. There's a bunch of types, and there are big, bad, scary types, and there are types that, you don't want them, but it's okay. We don't really do anything about them. Usually, like I said, these people are always going to have chest pain, and it's pretty acute chest pain, depending on how big the pneumothorax is. Usually they're going to be dyspneic, and oftentimes they'll have palpitations as well. So this is a plain film x-ray. As you can see over here on the normal side, you can see kind of lung markings. Keep touching that. I can't afford to if I break it, so let me not. But you can kind of see lung all the way here, all these lung markings all the way up. Everyone see it, right? On this side, obviously you do not, because here is their lung, and this is all air in your chest wall, right? So this should be all inflated, and it should be pretty close. You really shouldn't be able to even see the difference, right? And obviously you can. This is a really big pneumothorax. This is not one of the ones that I was talking to you guys about where we wouldn't do anything about this. This person is likely getting a chest tube. Okay? Okay, the big bad one that no one wants to ever have is a tension pneumothorax. And I think this is probably the ones that you guys are probably most familiar with because it's an emergency, right? Anything that's under tension, it's going to be an emergency. The signs of a tension pneumothorax are going to be completely different than like a spontaneous pneumothorax. These people are going to be hemodynamically unstable, typically, right? They're going to be altered. They're going to be hypotensive. They're going to be tachycardic. They're not going to be perfusing well oftentimes. It's other signs, the unilateral diminished or absent breath sounds. You can see that in any type of pneumothorax, the hypotension, the distended neck veins. This is something that I preach it a lot because it's taught a lot, but you often don't see that unless they're volume down. If they're volume down, you're not going to be able to see the distended neck veins, right? They're not going to get it. So I think, when you're looking for that, yes, look for it, but it's not always going to be there. Tracheal deviation, contralateral tracheal deviation, it's a very late sign as well. So when you're in the field, you also might not see that, right? So I've taken out two of the big signs that you have. So the best thing you need to be looking at is if they're hemodynamically stable and how they're looking. Are they talking to you? Are they confused and things like that? Because this tracheal deviation, the distended neck veins, which is what we're all taught, most of them are pretty late signs. It takes a little while, okay? So it depends on what time you got in there. Now, if they've had it for 2 hours, then you might get there and see it. But if it just happened, y'all probably won't see it when you're in the field. And the treatment is needle thoracostomy, and after a needle thoracostomy, most certainly a chest tube. See your needle decompression kit. Ferg, did you have some?
Yeah, I'm back here laughing. I feel like I'm at church. I'm saying yes. So you're saying what I say all the time as well. I agree 100%. And we did not talk about this. We're not trying to trick anybody. The goal to recognizing intention pneumothorax, the patient first has to have a pneumothorax, right? So you got to have signs and symptoms, mechanism of injury, decreased breath sounds, hypoxia, shot in the chest, beat with the back, car wreck, right? And then to get a tension pneumothorax, you got to have signs of tension, which is cardiovascular compromise. So that's cardiac arrest in the trauma patient with chest trauma, or it's altered mental status and poor perfusion, and that's when you fix it.
Yeah.
You can't go with tracheal deviation. The times that I've seen tracheal deviation has been on an X-ray, and that was too late because I should have picked it up clinically, right? But I'm not saying I didn't do that. The other times I go to intubate this guy from trauma arrest, I'm like, where are his cords? And I say, oh, look, they're pointing all the way over to the left. Why is that? Oh, because they have a tension pneumothorax. So those are late signs. Distended neck veins are great if your patient is not hypovolemic. If they have chest trauma and a tension pneumothorax, I would bet my $7 they're also hypovolemic. You won't get it. So that's what I was doing. I was laughing, and I was like in a choir back here. If they start singing, I'll be quiet.
Yeah, and the other thing I would remind everybody is we see it probably just as often in a lot of medical cases, like patients who have a tension develop after radiation for lung cancer and during cardiac arrest resuscitation.
Yeah, I say cardiac arrest a lot. You got a 70, 80, 90-year-old, you're doing chest compressions on, do you break ribs? Yes, you break ribs. That is trauma. So they're at high risk for having pneumothorax. Yeah. So therefore, if they have signs of a tension pneumothorax, you need to correct that. And for Alabama medics, that is category A, but you should be able to document and defend why you did it. So, cool.
Yeah. So, I mean, I think it's important to just know the late signs. And I think I'm trying to tell you guys what I see versus what you guys see. And I tend to not see the late signs because hopefully, like Ferg said, I would have figured it out by now and I would have handled it. You tend to not see these late signs, but they're very nice to pick up on a test question, right? So you got to kind of just remember what's the difference between like real life. So back to another chest X-ray. So we talked about air and what subacute emphysema kind of looks like on our Boerhaav's. But as you can kind of see, all of this, it should not like, okay, here's a normal side. And even here, he has some air kind of sleeping through, but it should look like this. All of this air here should get you moving. It should move you. It should make you very concerned. And as you can see, they have tracheal deviation. And the subacute emphysema is going all the way up into his neck. Now, these are the people, like you bring them into the trauma bay, and I'm trying to, in a very kind way, get medical students in there so they can touch the patient. Because once you feel crepitus, you will never, ever, ever forget it. It feels so odd, and it literally feels like you're popping bubbles under someone's skin. But in these type of patients, you're almost always going to feel it. And that's that's a pretty early sign. A lot of times, once it kind of starts escaping, the air doesn't stop, so it's kind of depositing. You'll be able to feel it early on. Okay. Any questions? Okay. I actually have never done a needle decompression. It's usually always done by the time they get to the hospital. I've done a bunch of chest tubes, but for needle decompressions, usually they're usually done by the time they get there, so I don't get to do them often. So fun for you guys. So this is a spontaneous pneumothorax. Usually we see these in young males. Oftentimes there's these diseases that kind of mess with your elasticity of your joints and your muscles, like Ehlers-Danlos and Marfan's. We won't get into that. But usually we see spontaneous pneumothoraces in people who are tall. Usually they're young, and typically they're healthy. Oftentimes, I saw one the other day, and he was like, yeah, I just been having a cough, and I cough real bad, and now my chest hurts. And I was like, oh, probably nothing. Sure enough, he had a pneumothorax. So if you can kind of see, this is if you don't look hard, it looks like a pretty normal chest X-ray. It'll catch you if you're not really looking. And so if you ever start reading chest x-rays, I highly recommend you read them the same way every single time. That way you don't miss anything. Because if you're looking at this just right here, it's like, oh, it looks normal. But then you can kind of see right here where his lung markings kind of stop. And they should go all the way out here. Do you guys see it? They should go all the way out and see it. So this is not huge. It's not small. I mean, it's not huge. It's not under tension. And usually, actually not usually, all the time, if they're unstable, it's tension, right? Someone like this for spontaneous, they're usually going to be fine. They're going to be a little uncomfortable. Vital signs are probably going to be normal. They might be a little anxious, but they're not going to look bad, okay? Usually for these, we don't do anything about it. Give them a little oxygen as needed, and we just observe them. I'll watch them, especially if it's at the beginning of my shift. I'll like just let them sound like, you're just gonna hang out with me my whole shift, and we'll get another chest X-ray in like 6 hours, right? If it's bigger in 6 hours, then that kind of changes things, right? But if it's the same, usually, oftentimes, I can't even tell that they had one on the 6-hour chest X-ray. And if that's the case, as long as they feel comfortable, we let them go home. Now, we do let them know, like, now, the first time you have this, you're probably going to have it again. So just be aware. But usually these patients do fine. We don't do anything for them. Everyone gets excited, like, oh, you got a pneumothorax. I'm like, yeah, I'm not doing anything about it. And they just get some oxygen and they get observed. Any questions on that? Okay. Pneumonia. This is infection of the lung parenchyma. Usually people are going to have fever, cough, pleuritic chest pain, fatigue. The treatment is antibiotics. Y'all probably see this all the time. And now that big bad COVID has kind of come into play, you probably see it way more than most people saw it 5 years ago. So we talk about normal chest x-ray. You see trachea, I can see their spine, lung markings on both sides. Heart looks like it's a normal size. It looks perfect. This person is really small. That's the only thing I'm looking at. They're really small. This is the bacterial pneumonia. You can see this is actually a really bad one. We tend to not, people usually don't make it this long not coming to the hospital. This looks really bad. So all of this right here, it still has lung markings, but all of this is just nastiness and bacteria. And even on this side, usually we see it in just like one lobe. I rarely see a bacterial pneumonia that's kind of just gone everywhere throughout the lungs. Like I said, people tend to not wait that long. Once they're uncomfortable and they having difficulty breathing, having chest pain, usually they come on in before it gets this bad. This is a viral pneumonia. Can't really see anything, right? Doesn't look super impressive. You might have some chronic changes here, but they determined that this person, I don't know if it's a guy, oh, it is a guy, has a viral pneumonia. You can have that, right? Chest x-rays aren't always that helpful in them, but a lot of times if it quacks like a duck, looks like a duck, it's a duck. COVID pneumonia, this is kind of a little new for us. We were seeing kind of whiteout pneumonias with some of the atypical bugs that cause pneumonia, but with COVID, you kind of just see just white everywhere. And it kind of just goes through. Usually they have a little fluid in there as well, so that kind of complicates it. But this is pretty typical of your COVID pneumonia, and this is pretty early on. It doesn't take COVID a long time to kind of make your lungs look like that. I remember how I was saying this takes like a long time. This person should have come to the emergency department a couple of days or a week ago. This is like day 2, day 3 of COVID. Right. But the good thing about this is now, I mean, typically, unless you're fine, I mean, if you're just coughing, having a little pain for COVID, I'm trying to not admit people to the hospital. Now, of course, people don't feel comfortable going home. They have COVID, their family's at home. They don't feel good. But if I can, I try not to admit people to the hospital for this, just because we're not doing anything for you that you can't do at home. Supportive care, Tylenol, just staying hydrated, and just, unfortunately feeling really bad for the next couple of days, but it usually, if you're normally healthy and don't have a bunch of risk factors, usually it'll just, go away on its own. That's not the case in Alabama, right? Most people have other, comorbidities that we have to think about and have to consider. So I try real hard not to admit these people to the hospital. It doesn't always work, but I really try for what it's worth. Any questions? It depends on, absolutely. Absolutely. And I try to be cognizant of how my patients feel, right? And if they feel comfortable going home, who's at home, do they have a bunch of people to take care of at home? Like a lot of that, depends on a lot of social factors as well. And so we try not to, and most patients are going to say like, no, I feel comfortable at home. I'd rather go home and sleep in my bed and I'll come back if I get worse. But it just doesn't always work out that way. And with these people who already have COPD and CHF and all of these things, I'd rather watch them closer, right? Costochondritis. So this is inflammation of the costal cartilages or sternal articulations. It's just a fancy word of what connects your ribs to your sternum. Usually it's younger patients, but a lot of times I see people with this kind of a lot, like after the flu or after they've had pneumonia from all that coughing. And it's not fun. It definitely hurts. The symptoms are going to be chest wall pain and sometimes pleuritic chest pain, but they should not be hemodynamically unstable. They should look fine. Usually they're going to be tender on their chest, which obviously if someone's having a heart attack, the odds of them having like tenderness to their chest wall is very slim. These people are going to have tenderness to palpation to their chest wall, and that's usually like a pretty key indicator. Now, costochondritis, like I said, is not something that you can just bring someone in, like, doc, they got chest pain. I'm like, costochondritis? Absolutely not. You have to, rule out all the big, bad, scary stuff. And usually I do that with a simple chest x-ray. And if I'm concerned enough, maybe a troponin, maybe some basic labs, and usually they're fine. And I give them some topical analgesic. Y'all should hear me talk up topical diclofenac. They don't pay me. They probably should, because I will talk this topical gel up like it's nobody's business, because it makes people feel better when you're confident in the medicine. Now, I've never had it, but I've heard that it works real good, okay? Also, NSAIDs, Tylenols, just doing basic stretches and things like that. Usually this goes away in like the next week or two and people are fine, but it's something that if someone presents to you, y'all go to somewhere presenting, and y'all have a patient who has some chest wall pain, he's young, healthy, he or she. I'm not trying to like just be mean to all the guys, but it's usually a guy, just saying. He's having some chest wall pain, tenderness, consider costochondritis. Any questions? Anything I wanted to talk about that we didn't talk about that's about non-cardiac chest pain? Thank y'all for listening. Y'all are a really good crowd.
So we did have a couple of questions online about, oddly, the costochondritis. I think we hear that a lot. We hear doctors tell people that maybe a lot. The specific question is, so what causes it?
So, like I said, it's inflammation in the costal cartilages and sternal articulations. Often, the most times I've seen it in Ferg, you can kind of say I usually see it after someone has had like some kind of viral syndrome, like a cough, something that causes cough, flu, pneumonia. A lot of people I saw had it after COVID, anything that you're coughing a lot and using those chest wall muscles and chest wall to cough, that's typically when I see it. Would you agree, Ferg? Yeah, absolutely. Mm-hmm.
Yeah, you can see it then, or minor car wrecks or falls, things of that nature. Is cartilage, right? It's like your knees, except you don't walk on your chest.
Yeah.
Well,
most of us don't.
Most of us don't.
Right.
Yeah. Gotcha. So the other question that came in is, what about cholecystitis? Can that or other epigastric pathologies, can those be causes of chest pain?
Absolutely. you can absolutely have chest pain. Usually it's more referred. These things that we talked about today are going to be chest pain. Usually if you're having chest pain with like cholecystitis or any kind of liver problems, usually it's a referred pain. And when I say referred pain, there is very complex neurophysiology that I won't get into because I don't remember it, that causes you to have referred pain from some of the organs in your belly to other places in your chest. For example, you can have, stuff in your spleen cause right or left chest wall pain. Left shoulder pain. So there are things that kind of refer to other areas, and that's when I see it. But absolutely, you can have chest pain in all of these. Any belly kind of etiology, you can have referred pain to your chest.
So I know for years in EMS, you see this, kind of comes and goes, but I think anybody that's worked in EMS in this region for a while has seen the medic have a patient complaining of chest pain, but the patient doesn't really look that bad, and they'll press on their chest and they'll say, "Does that make it feel worse?" And the patient says, "Yes," because they jump back because they just got poked in the chest. And the medic says, "Oh, well, it's not cardiac chest pain then." And then the assessment for cardiac chest pain stops at that point.
No, do not do that. I don't do that. If you come in with chest pain and I'm concerned enough, I'm going to get some basic stuff. So I wouldn't stop at that point. They deserve an EKG, right? All of these people deserve to be put on the monitor if they're having chest pain at all. A lot of times, especially if you're like me, I know I'm small and tiny, but my poke is mighty. I'll tell you that. And so once people are like, "Oh, you're so rough," but no, like if you're pressing on somebody's chest wall out of the blue and they're not expecting you to, like, yeah, they're like, "Ow, it hurts." So no, I would not do that. I think these people deserve an EKG. They deserve to be on the monitor. And I would treat it like chest pain, especially in a situation when you're out, by yourself. I would treat all of this stuff like chest pain. And you're not, I'm not going, you can't, even if you call me like on the red phone, I'm still gonna be like, nope, if they're having chest pain, it's chest pain. Now, obviously you can use, a little judgment, but I wouldn't just be so quick to say like, oh, this is costochondritis. Perfect.
Yeah, I agree. That's a diagnosis of exclusion in the ER. So one, if every patient was medically literate and trained and could give you a great history and be honest on their exam, then we'll be in a better spot. That's not the case in most of the patients that I deal with. And I don't mean that in a negative side. Even when I go to the doctor, I'll probably exaggerate or change things. But so this is a diagnosis of exclusion. So older person with chest pain, you think about the big bad things that kill people. Is there a pneumothorax, attention pneumothorax? Is there concerns for acute coronary syndrome? They need an EKG, things of that nature. So it's same thing with the GERD, right? Even if you got a 40-year-old saying that he had taco mama, last night for dinner, and now his chest hurts, it kind of burns, he's belching. Hey, roll tide with it. But he's getting a EKG, he's getting vital signs, a complete history, and I'm gonna recommend he goes to the hospital to get other objective data to look for those things. I would say that everyone in here that's been practicing paramedicine for a while, even medicine, has been burned by a patient just because it's not exact science, guys. What percentage of people have to have a certain symptom to be a classic finding? For example, if I was having a heart attack on TV, I'd be grabbing my chest, saying my chest hurts and it runs down my left arm. What percentage of people have to have that symptom for that to be in a textbook as a classic finding of acute coronary syndrome? Anybody know?
Somebody mentioned it once.
Yeah.
It's not.
It's like 25%.
Not a big threshold.
So that means that 25 out of 100 people having a heart attack may have that symptom. But what do the other 75 have? Well, short of breath, sweaty, nausea. My stomach hurts. Where's your stomach hurt? They point to the chest. Oh, that's your stomach. Great. Roll tide again. You just never know what you're going to get, right?
So what I would like to drive home, just as I wrap up, is that like all of these deserve respect, right? I think, especially as EMS calls increase, ED visits increase, it's not our job to get lax, and it's not our job to say like, oh, that person's not in pain, right? You have to still respect all of these. Like I said, Ferguson, literally just the other day, I had someone with a troponin of 1,000, and they were like literally chilling. She was just like, no, I got the flu. I just don't feel good. Can I just get some fluids and go home? And even after I told her she had a troponin of 1,000, she wanted to go home. I was like, probably not. So just respect all of these, but consider them when you're considering ACS. I think, acute cardiac coronary syndrome just gets the most love, and these deserve love too. Okay. Any more questions?
Yep. If nobody in the room has any questions, I think that did it for online. Well, just to say that, somebody just put a question here. Oh, no, not really a question. It's a comment on Roll Tide and War Eagle. So,
Roll Tide.
yeah. So, hey, everybody, we're going to take just a short break, maybe 5 or 7 minutes, and then we'll be back with Dr. Ferguson. So, thank you, everybody. Don't go far.
Hey, we'll get going. It's 10:05. We got about 55 minutes. Maybe not that long. So thank you, Dr. Douglas, for going first. I appreciate it. I was going to say earlier, why we call the residents in the hospital residents? Because they never get to go home. They're residents of the hospital. So thanks for your time this morning. I know you got to work trauma today. So obviously UAB, we get 12 residents. We have a year. We get 36 ER residents. We can get up to 2 EMS fellows. Those are guys that do EMS training with me after they finish their residency. So that's 38 fellows plus probably another 6 or 8 fellowships that are unaccredited. 99% of us are approachable in the ER when you bring a patient into UAB. Any of our 3 ERs, if you're concerned about that patient, find somebody in the gray scrubs or the green scrubs is our new color, and tell them, and they're there to help educate and train. We should work together, so do not be shy. The goal of the Department of EMS Challenge goal is to bring physicians and EMS back together. So reach out to us if you show up in our ERs. So we'd like to thank the Fire College for supporting us. As always, their support is invaluable because fire is EMS in our state. So I appreciate the Fire College support. What EMS Challenge is, I usually show this in the first hour, is kind of the history of it. We started this program back in 2014, 2013, I guess 2014, to bring more physician-led Con Ed out there. This is what Challenge stands for. I will not read this to you, but the goal is to improve patient care and take care of each other. This is the state of healthcare in America. So that's inappropriate humor. I was told I couldn't show that at some meetings, so I'm gonna show it here. Yeah, you can put that. Yeah, you can put that out, right? Yeah, actually, you can. As a EMS leader, you can put that out. We got to fix American healthcare, right? So you, me, the nursing admin, the hospital association, we can fix this. And if we can't, the citizens will. But people are having bad outcomes because the lack of us working together. If you want to scan this QR code, you can. This is what I need for the physician CME. We give physician and nursing Con Ed now. So every now and then, just somebody scan this QR code and give us an eval so we can keep getting that CME.
Yeah, that's different.
That's not today's attendance form. It's just it's a bonus QR code if you like QR codes, right? And I see a bunch of y'all taking pictures of it now. Thank you. Good job. Exciting. Sweet. We're at the state conference next week. We're in Jasper on December 13th. The 17th of January back at Talladega Super Speedway. Expect a big crowd there. You get to see some behind the scenes stuff. Last year we were at the Media Center. I think we're going to be there again, but super cool. And then we're in Alabaster on the 24th, and I'll post where we are the rest of the spring after that. What else we got going on? We'll be at the trauma conference in Pensacola into next week, and then I'll be in Austin. And then we also be presenting at FDIC this year as well, or I guess next year for the next one. And like Chief Ward was saying earlier, we do have some out-of-state partners. The Southern Region of Alaska EMS Council is a partner with us for Con Ed. Hopefully we'll have some of their physicians doing part of our lectures online for us in the winter. And then Julie Brown, one of our previous fellows who is now board certified in EMS, and Dr. Guttermuth, our current fellow, will be speaking at their conference next week, so they won't be at our conference, so it's the same time. I got the better deal, though. I'll be at the beach. They'll be in Alaska, but Alaska's great, too. So airway management, I'm going to show this slide until I quit seeing issues with it. I've been doing this for 6 months now, but airway management is an EMT skill that the advanced EMT should be a super master of, and the paramedic should be the super master of, all right? Things that kill people in the pre-hospital world is lack of oxygen and lack of appropriate airway management. So from simple maneuvers to oral airways to NPAs to BiADs, whether you're using iGels or Kings, whatever you got, to the ET tube,
to the flight medics that sometimes have to use scalpels, and that's a inside joke, cutting somebody's neck. But y'all should be the experts on airway management. There is no excuse. If you're having issues with this at your department, at your agency, reach out to your training officer, your chief, or your leader. If they can't help you, reach out to me, and we can make this happen. But it cannot be missed, right? Inappropriate humor that no one's texted me on. The second someone texts me why I show this picture, I'll quit showing it. No, you won't. You don't have a clue. So passive or apneic oxygenation. American Heart's been pushing for years that O2 is bad in cardiac arrest, in ACS or strokes or long-term with anybody. And I agree, they're free radicals. You can have some issues with that. But that's in patients that have been on high flow O2 for 6, 8, 12, 24 hours. You should not have patients that long. We know hypoxia kills people in the pre-hospital environment. We're seeing more and more return of spontaneous circulation in this region, which is great. And that's due to y'all's training and dedication to pit crew CPR, good airway management, early defibrillation. But what we're not seeing is people leaving the hospital alive. And one of the reasons is anoxic brain injury. So first folks on scene have to correct hypoxia. You do not have to ventilate them to correct that. I'm not saying don't ventilate people. I'm saying you need to oxygenate them first. So nasal cannula over the nose hole, that goes to your one tank, and it goes to 15 liters if they're altered, unresponsive, and not breathing. I recommend nasal trumpets. All right. If you're going to use an OPA, might as well stick an iGel or a King Airway in them. All right. Same risk. If they're not dead and they gag, they vomit, you screwed up. So nasal trumpet's a great way to do it. It provides a passageway to the lungs, and then there's the O2, right? My advice is the first O2 delivery device you use in the field is a nasal cannula. If the patient is upright, short of breath, talking to you, mildly tachypnic, nasal cannula at 2 liters. If that fixes them, great. Roll Tide, high five them, right? If it doesn't, crank it up. If they're still hypoxic and working hard when you're on 10 or 15 liters, get a second O2 tank at the rescue or your transporting agency, put a non-rebreather over that. You as a medic, if you think they're in pulmonary edema, do CPAP instead. All right. That's my advice on that. Cool. So passive or apneic oxygenation. Fantastic stuff. If you're using the iGels, and I don't sell these either, I wish I did, but I don't. All I'll sell you is sarcasm and bitterness. It's $10 a minute. There's a port on this. You pop that port off. This is not suction. This is O2 delivery, passive O2. So you can take your tubing off your ambu bag, hook it to this. You can take your tubing off your neb setup or pop it off your non-rebreather. If the patient is not breathing, so you get on scene, they're in cardiac arrest, they have no pulse, somebody's on their chest, you want to place an OPA instead of an OPA, you can do an iGel because it works just as well, but gives you a better way to ventilate them. You gently place the iGel in the mouth hole. You have one tank. That tank goes, tubing goes to the tank, and it plugs in here. This gives them high flow, passive O2. So now when it's time to roll them to get your Lucas or your Autopulse on, they're getting oxygen even when you don't ventilate them. Okay. When it's time to put them on that man sack or stretcher and move them down a few flights of steps, instead of kind of wishy-washy moving this around while you're bagging them, they're getting oxygen. I'm not saying don't ventilate, but I'm saying use this for your oxygenation. There are two things. There's oxygenation and ventilation. The other thing that we usually show in our labs is the fact that these ambu bags have a valve in them, right? And if your flow is high enough, you can get some flow past that valve. Otherwise, the only time you really get O2 through that ambu bag is when you squeeze it, right? And when you ventilate people in cardiac arrest or even in not cardiac arrest, you want to be doing about 1 every 6 seconds. You don't want to be doing a lot. You don't want to hyperventilate anybody except potentially metabolic acidosis or DKA. We're not going to talk about that. Airway confirmation is a medic. If you're placing an iGel or a King or AirQ, whatever blind insertion device you got, or an ET tube, you got to see waveform capnography. The EMT, the advanced EMT, you may not have that equipment. We're not going to hold you to the same standard. You need to be recognized. If you put an iGel in somebody as an EMT or advanced EMT and you're bagging them and their chest isn't moving and vomit is flying everywhere, it's probably not working. You need to pull it, reassess, reposition that airway, think of a different way to manage that patient. All right. But if you have access to capnography and if you're ALS transport, you got to have it, or ALS non-transport capnography. That IGL should have it. If you don't see a waveform in a number, you aren't ventilating them. It's time to reposition that airway, or it's time to break it out, put a nasal cannula on, passive O2, and put an ET tube in their mouth hole. You got video scopes where y'all are? Everybody got video scopes? It's like cheating, guys. Okay? It's like cheating. If you're going to use a video scope and intubate somebody, I would start off with nasal cannula at 15 liters. So you got to have a way to make sure the first responders know that. All right. So you can't be doing IGL, passive O2, then try to intubate, pull that nasal cannula and intubate. Have a process so every way is the same, or every day is the same in every crew. All right, let's talk about some stroke stuff. Mid-October, we kind of changed the triage and routing plan. We talked about this last week, and I've got numerous emails and texts about questions with this. So I wanted to hit it pretty hard again. IMSA, everybody in our region should have been trained the IMSA stroke scale. Now, this was probably 2 years ago. If you need a refresher, you can reach out to us at BRIMS or the state, or you can just pull up this information as well. But this is our new stroke assessment. It's the Emergency Medical Stroke Assessment, IMSA. It is a scoring tool. Super easy. We're looking for E, which is for eye movement. We're asking them to kind of, hey, look at my finger, go left, go right. Can they turn the head? If they won't do that, sometimes you want to yell at one side and yell at the other side, and you want to see those eyes move. So it's not just unilateral. If they can't do that, they get a check mark. Beep, they get a point. Potential stroke, right? The next thing is spatial weakness. Smile, blow your cheeks out. All right, looking for asymmetry. That gives you a point if it's positive. Arm weakness. The official rule is have them hold their arms up, both of them, count to 10. And if they drift or drop one side before that, that is weak. You can do 10 seconds. I can't count to 10 seconds. My ADD kicks in too quick. I get to about second 3 and I'm done. But I'm looking for asymmetric weakness of the arms. Same thing, asymmetric weakness on the legs. If both legs are weak, that doesn't count. It's got to be one side or the other. All right, so you got 1, 2, 3, 4 points there. The last is third speech or aphasia. Hey, what is this? This is my pen, right? Or if you don't like them, maybe you flip them off. Say, hey, what is this? They should say the bird, right? That was kind of funny. All right. Abnormal is third words. They say the wrong word or unable to speak. The guys in the fire service can point to your fire truck, say, what is that? Everybody knows what that is. And then repetition, ask them to ask something. Ask them to repeat what you say. This is the phrase the state recommends. You can do whatever. I usually ask them, say, can you repeat roll tide or war eagle? That generates a response from somebody in this state, right? Cool. That is the IMSA stroke scale. That is what we're using to put people into a stroke system. We have a system of care to get people who are having real ischemic strokes to the right place to prevent them from being paralyzed or having deficits for their entire life and to prevent death. So super cool stuff. Previously, before October, all strokes that were put in the system went to the most closest available green stroke hospital, Stoke Hospital. I was up late last night. So that could be a freestanding ER, that could be Brookwood freestanding or Gardendale, UABs. It could be Grandview, it could be Princeton, any available green stroke hospital. All you need is a CT scanner, a physician, and a thrombolytic. Then they can make a decision to go to a more advanced stroke center. As of October-ish, now patients with a verified IMSA score of 4 or greater and a last known well within 3.5 hours. And this last part really doesn't affect us in BRIMS. This will be important when we go statewide with this. Within 60 minutes of a thrombectomy capable hospital, these folks will be directed to the more advanced stroke center first, with the goal of getting that TPA, that thrombolytic, and then going in and removing that clot. So it's almost like a cath valve that we use for the heart, but for the brain, right? So that's changing a lot of things. So now we'll be seeing a lot of people with these big strokes, IMSA 4 or greater, within 3.5 hours, going to either UAB or Brookwood. Those are our 2 thrombectomy centers in our area. We are blessed to have 2. So when you call in TCC, they will ask for the IMSA score, and they'll help you go through this. It's a new process for all of us, but realize that if they're IMSA 4 or greater and meet that requirement at 3.5 hours, you're probably going to UAB or Brookwood. If they're not an IMSA 4 or greater, and we don't have a last known well within 3.5 hours, you're probably not going to UAB or Brookwood. And that's leaving UAB and Brookwood open to get more people in for thrombectomies that show up other places. Make sense? Sort of, kinda? Cool. Thank you for almost smiling. All right, the rules for IMSA. The patient must be able to participate in the exam. If they cannot follow commands, if they're unresponsive, if their GCS is 3, 4, 5, 6, okay, you can't do an IMSA. So if you can't do this exam, they can't be an IMSA or 4 better. All right, so they should be responsive to alert or verbal. They should not be responding to pain or unresponsive, because if it's one of these, you can't do this. And it's probably not an ischemic stroke. Okay, so that's a little bit new for us. Now, if you think this person is still having a stroke, so family says he had a headache, woke up this morning, starting to speech, couldn't use his right arm, and now he's twitching and jerking and not doing anything, and you think it's a stroke, more power to you. You can put them in TCC as a stroke, but it goes in under EMT discretion, and the odds are you will not go to UAB or to Brookwood because you cannot get an IMSA exam. All right. Cool. I know there'll be questions online at least in a few minutes. Sweet. So the triage severity-based stroke is IMSA 4 or greater, last known well within 3.5 hours, and within 60 minutes of transport time. Again, doesn't affect us a lot in Birmingham area. If those are positive, we're going to go to a thrombectomy center, UAB, or Brookwood. Things to think about when you're putting these people in the stroke system and general stroke care. Last known well, you got to have an IMSA. I would recommend that you get a contact number for family. Most neurologists aren't going to give somebody thrombolytic without talking to a family, somebody besides you or me, about this patient. All right. A lot of folks don't let the family write in. I'm fine with that. Write the number down in your glove, on your pants leg, on a piece of paper, on a tape. Give that number to the hospital when you get there. Super important, right? And then there's a checklist, right? Everybody seen the checklist in the state protocols? Anybody using it? Don't answer that question. So the checklist is basically going to have the IMSA on the top, and it's got these questions on the bottom. I'm not saying you got to fill this out and give it to the hospital. A lot of folks don't even use paper anymore, but I am saying you got to understand why we ask this question. Last known well, important. LOC, important to determine did we use the IMSA or not, okay? Glucometer reading. Every stroke, anybody altered, confused, needs a glucose, changes everything. All right. Was a fluid bolus given? Nah, I don't personally care, but you got to do that too, right? Yes or no? Why do we give a fluid bolus to somebody having a stroke? Anybody know? Yeah. The theory is increased blood pressure, so increases cerebral perfusion pressure. Exactly. Right. Yeah. Does it work? Man, I don't know, but we do it, right? Again, roll tide. I'm getting in so much trouble. All right. Questions you ask them with a stroke or family. And this is to determine, can they get that thrombolytic? History of a stroke, brain tumor, aneurysm, or AV malformation. That's a big word. I used to ask folks, any history of a brain bleed, a stroke, brain mass, cancer of the brain, recent cranial surgery. If the answer is yes, I cannot give them a blood thinner, a clot buster. Because if I do, and one of these leaks, the patient dies, and that's poor form for me to kill my patients, right? Are you pregnant? Obvious. All right. Any history of bleeding disorders? Are you a hemophiliac? Do you crap blood at night? Do you throw up blood? GI bleeding? Any recent surgeries in the last 2 months? All right. Those are the questions. And do you take a blood thinner? Not aspirin, but a blood thinner, right? I would say that 90% of the people that ask that question say, no, I take a blood pressure and aspirin. Is that the same? It's not the same, right? But these are things we have to know if we're going to lyse somebody. Right? And if they can't talk to us well, or they get worse between you and me, this information is invaluable. All right, so first case, 64-year-old complains of left-sided weakness since 9:30. They're alert, but they have difficulty speaking. They have marked left upper extremity, left lower extremity weakness. So I asked them to gaze left and right. They can follow my finger. They can look left. They can look right. So there's no unilateral gaze problem. They have a facial weakness, they have arm and leg weakness, and they have trouble speaking, so they get a point. So they have an IMSA of 4. All right, so far they meet the criteria to go to the thrombectomy center. When was their last known well? Somebody talk to me. Very good, very good. Yes, yes, yeah. 9:30. What question you want to ask them about this to confirm it was 9:30? Hey, dude, did you wake up at 9:30 this morning? And were you weak when you woke up? Because what if he woke up at 9:30 and he was weak? When was his last known well? When he went to sleep. Yeah, right. Yeah. So the question is, hey, if it's morning time, did you wake up with this, or did you wake up normal walkie-talkie and at 9:30 this all happened? Super important because it changes. If he woke up at 9:30 but went to bed at 7 p.m. last night, big difference in time, right? Cool. IMSA of 4, woke up at 8 this morning, 9:30 had the weakness, so he meets the criteria. Anybody know who this is? Anybody in the white back there? No clue. Yeah, you're too sophisticated. Yes, sir. I should know. Yeah, he knows. He just ain't saying. Right. Anybody know who that is? There you go. Morris Day. Yeah. Almost as cool as this guy, but not quite as cool. Morris Day and the time. Remember, the time is super important. Make sure you identify the time of last known well. Inappropriate humor, but I like it. That's Billy Squire, man. Oh my God. Help me, Lord. So dude's got an IMSA of 4. He's within 3.5 hours, and we're in the city of Birmingham or the suburbs. So this person goes TCC and he goes to UAB or Brookwood. All right. Cool. And the reason we do that is because now we can give them a thrombolytic, or actually we get the CAT scan to determine what type of stroke it is. Is it a hemorrhage? Is it ischemic? And then we can give them a thrombolytic, and then we can start rolling them out upstairs, go to the cath lab, and they can put a wire in that vessel, that large vessel. They kind of grind it up, evacuate it, pull that clot with the hopes of this patient who has this left-sided weakness and difficulty speaking wakes up and all of a sudden everything is fine. They go back to a normal life. There's a patient in Shelby County this recently happened to that they were sent not directly to the LVO center, but they were sent to another hospital. They got lysed, went to a thrombectomy center. They got a thrombectomy, and they went from huge deficits on one side to being discharged 3 days later at baseline. Huge save, right? Huge save. So this is a 44-year-old with a headache, left-sided weakness per the 911 call. You get on scene. He is nonverbal, kind of gazing to the right. He won't open his eyes to pain. He kind of withdraws on the left side, but doesn't move that right side at all. His IMSA stroke scale will be what? Bueller? 5. Who agrees with 5? Who said 5? Somebody in a white shirt. Nobody's going to disagree with that guy. He's got a white shirt on, right? Yes, I know, but I set you up for failure. That's what I do, right? I'm a parent. Sorry. That was really funny. Cool. What's the problem here? He cannot participate in the exam, so he kind of withdraws to pain on the left side. So yeah, he could be having a stroke, but I can't do an IMSA exam because he's responsive to pain only. So I can still, hey, TCC, this is what I got. I can't give him an IMSA score. You will probably not be directed to a thrombectomy center because he's unresponsive or actually responds to pain only. But I agree, there's something strokey going on with this guy, right? That's another term, strokey. Yeah. So why is this important? Because there are a lot of stroke mimics out there. There's also other types of strokes. There's hemorrhagic and there's ischemic. Ischemic strokes, the clots we can treat. Hemorrhagic strokes, we can kind of treat, but the outcome is not near as good, right? So a lot of mimics out there. One of the big ones is a hemorrhagic stroke, and this is the ruptured blood vessel. They may have a headache. They may have altered mental status. They may start off like an ischemic with some left-sided weakness and slurred speech. The problem is this vessel ruptures and it bleeds into the head. They get more head pain. They eventually become unresponsive, and that's bad. So if that stroke is maturing in front of you as you're working with this patient and they're becoming more and more altered, odds are it's hemorrhagic. Most of the time, these guys are super hypertensive, okay? But there's really no way to tell until you get a CT scan. And the other type is the clots, right? That's where you get a vessel that's either narrowed due to age, or a clot breaks off somewhere in the carotids, or maybe you throw a clot from your AFib and it blocks the arteries to the brain. Those we can treat with TPA or thrombectomies. What about this one? 64-year-old confused, opens eyes to verbal, but will not obey commands, history of a stroke, but moves all extremities, but kind of weak, kind of growling at you, moving around. Is that a stroke? Probably not a stroke, yeah. If you think it's a stroke, you want to put it in the stroke system, it'd be put in under EMP discretion. I probably would not, but it is what it is. Currently, our stroke system for the state is more of a neurological emergency system. Numbers about a third of the people put in to the stroke system are actually having strokes. About half of the rest are having some kind of bad neurological problem. Okay, and the rest is nothing quite as significant. So we're trying to capture more ischemic strokes because we can treat those, and we don't want to fill up the neurology teams at certain hospitals with non-strokes. We want them to have space to take care of the others. So probably not a stroke. 64-year-old history of a TIA, left side of weakness in the past, but it gotten better. Now left side's weak again, confused, but follows commands, can't raise the left arm or leg, can't repeat words, slurred speech. So what is their IMSA? I'd say it's at least a 4, right? We didn't even talk about the eyeballs, but we got facial, arm, leg, and can't speak, right? Can't repeat words. So that's a big IMSA. Would you say that would be a stroke? Yes or no? Yeah, yeah. So what is a TIA? A stroke that goes away is a transient ischemic attack. That's a big red flag that you're probably going to have a stroke on down the road. So that should be a super red flag that, hey, this is probably the real deal. It's also a reassuring fact because that makes me think more of a clot than a bleed because they had a TA to begin with in the past. So yeah, this is going to be, hey, TCC, I got an IMSA of 4. I got to find out the last known well. I'm going to get an AccuCheck, right? I'm going to put them in the system, and I'm probably going to a thrombectomy center, Brookwood or UAB. Billy Squire, the stroke. There you go. Yeah.
Hey, Doc, let me interrupt you and get through a couple of questions that come in. So we had one comment about a particular case. I think they've been directed to email Michael Miner in the chat, but apparently I've gotten some other comments that I didn't publish that folks have called TCC and they were diverted away from UAB and then got to that hospital and the patient ended up being transferred back to UAB for thrombectomy.
Yes.
And so that can happen. The system's not going to be perfect.
Right. Well, that's also the way the system is also set up. So if I had an IMSA score of 2 and we get to the hospital and we scan them and we say, holy crud bucket, I can see on that scan there's a big clot in a big vessel. That hospital is going to give them a thrombolytic to start breaking that clot up, and then we can expedite transfer. It's a one call, does it all to a thrombectomy center, and that takes the weight off the thrombectomy centers. Just because you're an IMSA of 2 doesn't mean you may not have an LVO here in the next few minutes.
Yeah, but I agree with you. That's great. In this particular instance, the IMSA was initially greater than 4, so they were just directed inaccurately.
Okay.
And that's going to happen,
right?
Especially as we crank the system up and everybody gets used to it.
Right.
So I guess my comment there was for everybody to be nice and patient.
Oh, forgive me. Yes, sir. No, I agree. Yeah, it's a system approach. There are going to be some errors. The goal is we need to utilize this system because it really makes a big difference when we get somebody to one hospital that we can move them to the next. And we're trying to utilize the thrombectomy centers for the ischemic big strokes. But there will be some issues. If you have issues, reach out to Mr. Miner or myself. And yes, please be professional. We're trying to make this work. And I get it. Some days are bad days, but the system's going to save lives. And it does work when it's used appropriately for the most part.
So the other, you mentioned a couple of times that if the patient doesn't have an IMSA greater than 4, or if they're not alert or verbally alert, then you're probably not going to be directed towards either UAB or Brookwood.
There's a potential for that, yes.
So the questions that are coming in were, hey, what about if that's the patient's choice or the family's choice, that they have a history of neurological care at UAB or Brookwood?
Yes. So When you think about destination hospitals, if the patient is attached to one hospital, in theory, they should go to that hospital if at all possible because they have the records and so forth. So if you have a complicated neurological patient that's usually only seen at UAB, they probably should go there. But that's information you should share with TCC as well.
Yeah, regardless of the other criteria.
Regardless of the other criteria. Now, that being said, for system entry, for the most part, my advice is go where TCC says because they know what the whole system is like, especially trauma. But it goes for stroke and STEMI as well. Not as significant for those two, but especially for trauma.
So the last one, and then I'll let you get back to it.
Yes, sir.
Sorry. This one's a little bit more in depth.
Uh-oh.
So a lot of patients that have had TIA or have a history of uncontrolled AFib or taken Eliquis or similar drug, which makes them ineligible for TPA.
Yes, ineligible for TPA, but eligible for thrombectomy.
So that's the heart of the
Correct.
question. If you know they're taking Eliquis, maybe they have an IMSA of 3, they're taking Eliquis, should they be directed to the thrombectomy centers?
That is not the way it's set up right now.
Okay,
At some point in the future, that seems super reasonable. We are not there yet. My thoughts.
got you. Okay, thank you.
Yes, sir. Ooh, I almost got through that. It's pretty good, wasn't it? I did good. 64-year-old unresponsive, glucose reads high, and they're seizing. What is their IMSA? Can't do it, right? Cool. All right, cool. Because they're unresponsive and seizing. So when I see someone unresponsive, altered, seizing, and they were having stroke-like symptoms, my brain automatically goes to thinking they have blood in their head. Big risk factor for seizures, all right? So let's talk about seizures. Get it? I did this last night too. Seizures, right? So what makes a seizure? What things can cause seizures? Anybody know? Anybody care? Matt, any kind of lettuce. Burgers make you not seize, but yeah. So the easy thing, the baseline people think about is epilepsy, right? A seizure disorder, right? That's not super concerning. If they have a history of seizure and they have a seizure, they've already been worked up to the hilt at some point, and we know they have seizures, and they should be on anti-seizure medicines. So not super concerning, right? So the kind of base thoughts of seizures is, do they have a seizure disorder? As an EMS professional, as an ER doctor, that's not the first thing I should think about. If they have a seizure disorder, I do care about that, but I'm not super concerned about it because we know they have that. They've been evaluated. It's not something more scary that potentially could kill them in the next few minutes, for the most part, right? All right, what else can make a seizure? Oh, that's a good one. We'll come back to that one. Yeah, I forgot about that one. Thank you. Good job. Great. All right, next. All right. I was thinking more like hypoxia or airway issues can make you seize, right? So poor perfusion to the brain, no O to the brain, people start twitching and jerking, airway issues. You as an EMS professional should be able to manage airways. So if someone is seizing, one of the first things you should be doing is reaching down, trying to open the airway with the jaw thrust. If they're biting down, you can't do it. The foam at the mouth, you roll them to the side. Somebody's giving me some O2 by nasal cannula. I'm probably getting a nasal trumpet. I'm gonna lubricate it with their saliva, not mine. Gently place it in their nose hole. O2 goes on, right? I'm managing the airway. Airway management is a priority. We've kind of stepped away from that with the use of iGels and Kings and things, but airway management from BLS to ET tubes, airway management, super important. All right, what else can make a seizure? You see what I'm doing here? I'm putting the different parts of the salad. Oh, I like that. Who said hypoglycemia? Fantastic. So electrolytes. So low blood sugar. You get a low blood sugar, you're going to start tripping and seizing, right? So you should recognize that. So guys on the floor seizing, you're going to roll over, open the airway, suction it out, nasal cannula, nasal trumpet. All right. I'm making sure he has a pulse too, right? And then I'm going to start thinking about electrolytes. Somebody get an AccuCheck. What's his blood glucose? If it reads low, you know what the problem is. If it reads high, you can assume is another electrolyte problem. People who have high glucose could be in DKA and dehydrated. They could be hyponatremic. All right, that's more for the critical care guys out there. But you'll recognize those problems, right? So glucose reads low. What are you going to give him as a medic? D50, D10, D25, whatever you got, right? Not a bag of Skittles, right? In his mouth all while he's seizing, but IV that. Anybody carrying glucagon anymore? Yeah, way too expensive. So what if you can't get IV access? What are you going to do? Drill them and then get glucose. Can you give dextrose through an IO? The answer is yes. Should you drill your routine twice a week patient that calls you for help twice a week to give them glucose? No. But if the patient is seizing, dying, unresponsive, altered, obtunded in front of you and you can't get IV access and the glucose is low, you drill them and give glucose. People will die from hypoglycemia. Cool. Excellente. You recognize the glucose shreds, right? Cool. What else goes in a seizure? What else can cause seizures? Hear that? Yeah. Good, good, good. I was thinking with this more like hypovolemia. So dehydration, syncope can make you get from dehydration. Okay. Massive anemia, acute blood loss can make you have a seizure-like disorder because the brain doesn't get the blood supply it needs. So volume resuscitation is also important with seizures. What else can cause seizures? I was just really tired last night. What? And hungry. Well, I wasn't that hungry. It was a salad. We're getting there. Structural problems. So this could be blood in the head, a fall, the subdural with shift and epidural, hemorrhagic stroke, blood in the brain can cause seizures. So structural issues, right? And then what else we got? Somebody said this one. What about this? What is this one? This is a good one. Yeah. Yeah. Drugs. Get it? The fork is up there. Fork. Oh my God. All right. So drugs. So too much cocaine, meth, other things. Alcohol withdrawal can make you have seizures. People die from those. People on chronic benzos. So the 74-year-old lady who's had anxiety since 1972 and been on Ativan since 1973 runs out of her Ativan. Now she's seizing, probably because she's a benzo withdrawal. So drugs, right? And then the other things you think about, cardiac arrest, dysrhythmias, and those are all kind of leading to hypotension, and you can have problems with that. So any seizure, you're always managing the airway and reach around feeling a pulse. Obviously, if they're in cardiac arrest, they're going to seize for a few minutes, about 2, maybe 3, and then quit seizing, and you think everything's great, but then you're like, oh, that's not great. Now they have no pulse because they went from being in VTAC, VFib to being into nothing, right? So seizures. So what was the joke with this one? So sometimes the seizure is not what it appears to be. That's cardiac arrest. Or like salad dressing sometimes is not what it appears to be. Get it? Cat? All right. Tough crowd. I really enjoyed doing those slides though. So management of seizures is simple airway maneuvers we talked about. Open the airway, jaw thrust. If they're clenched down, nasal trumpet. Unresponsive, they not clenched down, you can do OPAs or biads. Intubate them. I've never seen a patient that was having a seizure that needed a surgical airway. Well, I say that, weird story, but I won't tell it here. But airway management, prevent hypoxia. That's how you manage that salad, the seizure salad. IV fluid, check a glucose. Once you are done your airway, your breathing, you assume they have good circulation. You've got a glucose and it's normal. You give an IV fluids. Then you can start recognizing the fact they need some benzos. You can do some Versed in our state. The flight guys can give Ativan. If you still have Valium, you can do that. But Versed is fantastic. The advanced EMT can give nasal Versed, but Versed is great. If the is a structural problem from a head injury or a stroke, remember the 3 things that prevents worsening of head injuries. 1 is prevent hypoxia. 2 is prevent hypotension, so we're giving fluids. And 3 is prevent hyperventilation. You do not want to blow off that CO2 on those people, right? So again, even if they're not breathing post a seizure, right, we're not bagging them at 30 times a minute. Nasal trumpets in, passive O2's on, ambu bags over the face, and I'm breathing every 6 seconds. And it's going to feel like a lifetime between each ventilation. But whoever's doing it, that is your job, right? And then dysrhythmia recognition as well. Going them on a 3 lead to get the pads on. What kind of rhythm we got? Cool. Now, here's why I say anything else, and this is where you say eclampsia. Very good. Other things can cause seizures too, right? Eclampsia. What makes you, first, how do you get eclamptic? You get pre-eclamptic first. Good. And what do you get pre-eclamptic? Pregnant. Yeah. Very good. Wes is a scholar. Yes. Yeah. Right. So, it's some kind of, the body recognizes the baby as some kind of toxin. I forgot the patho, like Dr. Douglas would say. I'm not sure, but usually you got to be pregnant or have been pregnant recently to have eclamptic seizures. So how do you manage an eclamptic seizure? What do you do different? Yeah. When do you do the MAG? When do you do what? Yeah, I would say you're still doing your ABCs first, right? So I'm still going to do the same thing. I'm going to be doing airway, suction it out, NPA, passive O2 on 15 liters. I'm checking an AccuCheck. I'm starting my fluids. I'm getting them on the monitor. If they're still twitching and jerking, and I look down and they are gravid, they got a baby in the belly, I'm giving a MAG. If they don't, I'm giving them Versed. If I give the Versed, then I look down and go, oh crap, I think they're pregnant. Then what I do? Then I give them the MAG. They got Versed first. If family says, hey, she had a baby 4 days ago, what is up? And she doesn't have a baby bump. Can you say that? I don't know if I can say that. Let me take that back. If she had a baby 4 days ago, but she does not have obvious signs of current pregnancy, right? She can still get MAG. You can have eclamptic seizures up to a couple of weeks postpartum, and they keep changing that literature. It used to be 6 weeks. What do they say now? Is it 2, 4 months? See that? Yeah. So yeah, right. What is the risk of giving someone magnesium? You give too much and get hypotensive. The other risk, you get fussed at in the ER. If they're seizing, are pregnant, or recently had a baby, they can get magnesium. There's no risk to that drug. And if they fuss at you, smile like you're married, and then email your EMS chief, and then you can email me. Cool. What was that? Oh, this is back to the volume. Remember, always with seizures, think about cardiac arrest, dysrhythmias, perfusion status. All right. All right, we got a couple minutes. Let's talk about hypertension. I know some crews are carrying the beta law. Hypertension in the ER, we manage this when it's signs of end organ failure, and that's usually not till blood pressures are over about 200 over 120. So 180 over 70, people come in the ER all the time. My blood pressure is high. You got to fix it. I'm like, dude, mine was twice that this morning. You're going to be fine. We'll treat you, but treat you slowly, right? So end organ failure. There are some things that we want to treat hypertension for, and there are other drugs out there besides the blood pressure medicines per se. So this is a 50-year-old female, history of hypertension, cardiac disease, blood pressure is 170 over 100, heart rate's in the 80s, respiration 16, set 99%, and she's having chest pain. So you get this 12 lead, you have IV access, you're doing some pre-oxygenation because of her history makes you uncomfortable. You throw on the monitor. You got to decide STEMI or no STEMI because she's having chest pain. And they say, hey, can you treat her hypertension? How are you going to treat her hypertension? And would you, and why would you? Kind of weird questions. It's like I'm watching a game show. These guys are talking about each other. And the answer is, what drug would you give her? It's 170 over 102. No, perfect. Yeah. So inferior STEMI, all right. Even if it was not inferior STEMI, she's having chest pain. I can give her some nitro. I give her to her for chest pain. That's a sign of end organ failure, end organ damage from bad hypertension, right? So nitro is appropriate. I want to give her the other drugs, the Betadol, the Cardizem, like the state says we can. So Papa Nitro, he made the question, can you give nitro in inferior MIs? You can. There's a big risk that this is right ventricular and you can drop their blood pressure. Always, as a medic or an advanced EMT, before you give nitro, put an IV in them. So that way, if you drop the blood pressure, you can fix the blood pressure problem, right? But I would say a blood pressure of 170 over 100, yeah, a nitro is not going to hurt you. If the blood pressure was 100 systolic, nope, I'm not giving you nitro, right? Make sense? 100, 120 is kind of all gestalt. I think the textbooks talk about saying 100. I would be uncomfortable giving someone nitro with a blood pressure of 100. I would probably do IV fluids and then give them some fentanyl first and see if that fixed the problem. All right. What drug do they have to get though? What drug, if they're having a STEMI, do they have to get? Starts with an A, aspirin. Yes, not alcohol. Very good. Thank you. That's good. Yeah, yeah. Firemen are smart. I like this. This is good. So hypertension. What about this dude? This dude's got blood pressure 210 over 110. His last known well was 45 minutes ago. He's got a facial droops, third speech. He can't use his left arm. His IMSA is 4. So you got an Accu-Check. Glucose is 90. You're going to a hospital. Does he need blood pressure control? And if so, what drug would you give him? Remember, I trick people. That's what I do. Yeah, I would say no. So if he's having a hemorrhagic stroke, if he's got blood squirting out, yeah, we want to lower that blood pressure so that doesn't make the bleeding worse. If he has no blood squirting out, I want this blood pressure high to perfuse the rest of the brain. Okay? So how do I know if he's got blood squirting out or no blood squirting out? Yeah, you don't, right? I would say if it becomes altered unresponsive and starts seizing, he's got a hemorrhagic stroke. But I'm still not going to give him some for his blood pressure until I manage his airway, check a glucose, give him some fluids, think about electrolytes, and I get him to a CAT scanner and I see that blood. At that point, I'm like, okay, game has now changed. I'm going to lower his blood pressure down to about 160 systolic. Okay. If I don't see blood, I'm content with this. Now, if I'm going to give him TPA, TNK, a clot buster, I got to lower it just a little bit because the risk of a ruptured vessel down the road is higher. But I'm not going to get in that. That's way deep in the woods for you guys and even for me sometimes. Make sense? What about this one? Got a few minutes still, Chief. We're good? Yeah. This is a 56-year-old Alabama fan. Has end-stage renal disease. He did dialysis 4 days ago. Didn't do it the weekend because he was watching the LSU game and got drunk and passed out and missed his dialysis treatment. You like the way I'm doing that. He complains of shortness of breath. He's a little bit tacky in the 100 range, breathing 28 times a minute. He's sat in 88%. His blood pressure is 200 over 128. That's a great EMT there, 128. On exam, he's alert, he's anxious, he's got wet lung fields, he won't lay flat, he's sitting up, his legs are swollen, his belly is swollen. What's going on with him? Yeah, CHF. I would say it changed that terminology to say that pulmonary edema. Lots of folks have congestive heart failure. They all don't get pulmonary edema. Pulmonary edema is what kills you for our standpoint. So I would say CHF, end-stage renal disease, yes. But what he's got now is pulmonary edema. He's got fluid in his lungs, right? So when I think about management pulmonary edema, I think about a mnemonic. I'm good with the ABCD, and I'm good with this one, LMNOP. The rest kind of confuse me. So the way I think about this is, dude has volume, fluid in his lungs, and he's hypertensive. So he's so hypertensive, it's hard for him to push the fluid out of his lungs because the blood pressure is so high. So what I want to do is I want to sit him up, get a good position to make sure that the fluid stays low. We can aerate the top. If I lay him flat, the fluid layers out and will cover up the main stems of the right and left bronchus, and he'll drown, right? So I sit him up and I think about oxygen, and how would I give him oxygen? CPAP, yeah. So the first thing I'm going to do is the first guy I'm seeing, the EMT, is going to recognize dude's huffing and puffing. He's hypoxic. He's not breathing well. I take my one tank, I put it up to O2, nasal cannula on 15 liters. The medic comes in with more stuff and says, oh, yeah, he's got CHF. He's in pulmonary edema. So now the medic's going to have a second tank, or you're going to move to the transporting unit and put the mask on him with the CPAP, hook it up to oxygen. And we're going to oxygenate the living crap out of this dude. All right. So CPAP does two things. It helps improve oxygenation and it pushes the fluid out of the lungs. And what does CPAP do to blood pressure? Lowers it, right? Because that's a contraindication. If it's hypotensive, you can't do CPAP or BiPAP. So I'm gonna lower his blood pressure, improve oxygenation, and push the fluid out. When I lower his blood pressure, the heart beats better and the fluid comes out. CPAP, BiPAP is like cheap, right? So position and pressure, most important things. Oxygen, right? Oxygen really should be down here before this, but it didn't fit my mnemonic, right? Nitro, due to super hypertensive, I'm not going to bottom him out. Nitro is a vasodilator. It helps remove some of this fluid going back to the heart. So I got him on the nasal cannula. Somebody's working on IV access. They put him on the pads. We're getting a 12 lead. Somebody's going to get a second tank. Right before I put that CPAP on his face, I'm going to say, there's one nitro, sir. Oh, now it's been 5 minutes. One more. I put the mask over them and we're good to go. You can use some morphine that makes them kind of chillax. Morphine is also a dirty narcotic. It drops your blood pressure, may help with perfusion. This usually works alone. You can add this. Do not add ketamine. And I will not do fentanyl. Fentanyl does nothing to blood pressure, and ketamine is going to make them get crazy, right? And then you can do some Lasix. If they're a dialysis patient and don't pee, I'm not going to give them Lasix anyway. But if you want to give Lasix, that's fine. That'll be the very last thing you do because it takes a few minutes for it to work. Sweet. Questions, comments, statements? I got slides for hours, but I think time is about done. Yep. Yes, yes, you can do that. Right. Yeah. Yeah. So the risk of giving someone nitro having an inferior MI in theory is that you drop their blood pressure because you decrease preload. My experience is if they're hypotensive and bradycardic already, they don't need nitro, but that's a duh. We shouldn't be giving them nitro anyway. Have I given nitro to people having inferior MIs who are hypertensive and tachycardic and I've lowered their blood pressure? Yes, I have. But sometimes I still do it, right? It's just a risk. A lot of times in the hospital, I'll do IV nitro. So that way, if I drop the blood pressure, I can cut it off and it's gone in seconds versus the big slug that y'all get. Other questions, comments, statements within reason?
Hey, Doug, we had a little bit of sidebar conversation going on about
Salad bar
Caesar's,
conversation?
Caesar salad bar conversation.
There you
Yes.
go. Yeah.
The ideas that you were kind of inferring about differences between ischemic and hemorrhagic and associating seizure more with hemorrhagic.
Yes.
I would just want to kind of reemphasize, make sure you agree with this statement, that we can't tell whether a stroke is ischemic or hemorrhagic without a CT scan.
Correct.
And you can definitely have patients seize who are having an ischemic stroke.
Correct. You can also have patients having stroke-like symptoms and seize and it not be a stroke. It could be electrolytes.
Yep.
They could be hyperosmolar. They could be low sodium. They could have an underlying seizure disorder we don't know about. They could have had a stroke 2 years ago and that part of the brain had issues and now they're having seizures from that stroke. So it's not always.
Yeah. So like, after the previous lecture, we were talking about how many signs and symptoms do you have before it's considered classic, and that threshold's pretty low.
Yes.
And to me, that idea even applies more to stroke,
Right.
because it can really be all over the board with signs and
Yes.
symptoms, right?
Right. Yeah. The other thing is there are going to be strokes that other people, providers think are strokes that you may not, and vice versa. I can tell you that there are a lot of things that we see at a stroke center that are like, that doesn't look like a stroke to me. And neurologists are like, oh no, that's definitely a stroke, right? You know what I mean? And there have been things that I've said, this is a stroke, and I get an MRI, and it's like, oh, there's no stroke there. It's a migraine. Yeah, it's a migraine. It's Todd's paralysis, right? So it's super confusing. The goal here is you don't want to miss the things that hurt people. So my advice is have a standard approach to how you assess for these strokes and realize sometimes you're going to overcall them, and that's okay. Better to overcall than undercall. In the management of seizures, have a standard approach of how you're going to manage these people and recognize only certain things you can fix. If someone's had a hemorrhagic stroke and they're seizing from that, you can't fix that. I can't fix that. Okay. But I can go through a checklist and make sure that they're not hypoxic, the glucose is fine, the airway's being managed, they're getting fluid resuscitation. And then when all that is done, I can say, well, crap, that didn't fix it. They're still seizing. I think there's blood in the head. I can get them to where they need to go. And you can do the same thing.
Yep, great.
Cool.
So the other questions were about, hey, we're still giving fluid bolus if their lungs aren't wet, and we're still trying to lay
Yeah.
them flat if they can tolerate it for stroke patients, right?
Yeah.
And that's all to maintain blood pressure, to
Yes.
maintain perfusion to the
Yeah,
brain.
it is. Yeah.
Right. So the
I'm-
last thing we'd want to do is give them something like labetalol if they're having stroke symptoms
Yes.
in the
Yes.
pre-hospital
Do
setting.
not give labetalol cardiacs for strokes is in the field. I know the state says you can for hypertension. You don't. Do not give nitroglycerin to a stroke in the field because that's all you have to treat blood pressure. My point to the blood pressure is if it's low, you got to fix it. If it's high, meh, you probably don't in the field, right?
Very good.
All right, Dr. Douglas, you got anything to add? Right. Yeah, we can drop. Yeah, I would too. Right. Right. We can always lower it down pretty quick. Sometimes too quick.
It was great. Couple of great lectures today. Anybody in the room have any other questions for the docs? I think we've gone through most of the themes that we saw online. And hey, thanks, Dr. Ferguson. Thanks, Dr. Douglas, for the lecture today. Thanks for everybody that came in person and participated online. Please remember to submit an attendance form. If you're here, I'll put the QR code back up on the screen here in just a minute. I'll also do that online. If you're online, you can go to the Q&A feature and scroll up. The link to the attendance form is in there. The password for today's attendance form is CHEST, the word CHEST, all lowercase. That's going to be the first question. Please submit an attendance form even if you don't need the CEUs. If none of those mechanisms work, you can send an email to alabamaemschallenge@gmail.com. You'll get an automated reply with a link to the attendance form that way. And next week, a week from today, we'll be in Orange Beach, Alabama, right, Doc? At the Alabama EMS conference. We'll be broadcasting the EMS challenge from the conference.
Yes, sir. I'll
for-
be talking about anticoagulation, maybe some volume resuscitation. Dr. Melissa Willett Caldwell will be talking about surgical airways. And then we're going to do a critical care lecture on kind of lab evaluation. And then we're going to talk about pit crew CPR and how to develop a good program with Matt Panapinto as well. So a lot of things
Okay.
going on.
Sounds great. Yep. So all that's good. We're glad to welcome Dr. Willett Caldwell back as a lecturer. She's been gone for a couple of months after she finished her fellowship, and always good to hear from Panapinto, who's one of our instructors here at Jeff State. And thank y'all, everybody, for participating, and hopefully we'll see you at the EMS conference.